Hello, my name is Dr. Dennis Yang, and I'm an assistant professor and interventional endoscopist at the University of Florida in Gainesville, Florida. On behalf of myself and my co-authors, I want to thank Gastrointestinal Endoscopy for allowing us to discuss the results of a recent meta-analysis on endoscopic submucosal dissection for the treatment of Barrett's neoplasia. As we all know, the incidence of esophageal adenocarcinoma has been increasing at an alarming rate in the Western world. We also know that Barrett's esophagus is the main precursor of esophageal adenocarcinoma. With advances in endoscopic techniques over the last several decades, endoscopic mucosal resection, or EMR, of visible lesions in conjunction with endoscopic ablation of the residual Barrett segment has become the standard of care for the management of patients with Barrett's neoplasia. Endoscopic submucosal dissection, or ESD, is a technique initially developed in Japan for the en-bloc resection management of superficial GI neoplasia. When compared to EMR, recent data suggests that ESD is superior in terms of en-bloc resection, curative resection, and associated with a lower recurrence rate. However, the role of ESD for the treatment of Barrett's neoplasia is now well defined. So the purpose of our study was to conduct a meta-analysis to evaluate the efficacy and safety of ESD for the treatment of Barrett's esophagus. We identified studies by performing a comprehensive literature search of 3 main electronic databases, and we included all studies reporting clinical outcomes of ESD for the treatment of Barrett's. We excluded all animal studies, case reports, studies in which ESD was done for esophageal adenocarcinoma not arising from Barrett's esophagus, or in those studies in which a hybrid ESD technique was used. The main outcome measures are summarized in this slide. En-bloc resection was defined as complete excision of the target lesion in one piece. R0, or curative resection, was determined when the lateral and deep margins were negative for Barrett's neoplasia. Curative resection was then defined as R0 resection in the specimen with well to moderate differentiated histology, absence of deep submucosal invasion, or lymphovascular involvement. Recurrence was determined by evidence of histologically confirmed Barrett's neoplasia at the prior resection site on follow-up. Adverse events were measured and included perforation, bleeding, and esophageal stricture formation. In total, 2396 studies were identified through our query, of which 425 were duplicates. Out of the remaining 1971 studies, an additional 1696 were deemed irrelevant based on title and abstract review. Full text review was then performed on 275 studies using the predefined inclusion-exclusion criteria, and after which 11 studies were retained. So out of the 11 studies included, 3 originated from Japan, 7 from Europe, and 1 was a multi-center study from the United States. In all, ESD was performed in 501 patients for 524 lesions. The mean lesion size was approximately 3 centimeters with an average procedure time under 2 hours. This slide summarizes the main outcome measures. The pulled en-bloc resection rate was nearly 93% with little heterogeneity. In contrast, there was significant heterogeneity for the R0 and curative resection rates, which were estimated to be around 75 and 65% respectively. In terms of adverse events, the incidence of either bleeding or perforation was reported on 1.8% and 1.5% respectively. Both bleeding and perforation were managed endoscopically without requiring blood transfusions or additional interventions. Esophageal stricture formation was the most common delayed adverse event, with a pull rate near 12%. Similarly, all these patients were treated successfully with serial dilations. For lesions where curative resection was achieved, recurrence was reported in 0.16% at a median follow-up of 23 months. So, in all, our results of our meta-analysis suggest that ESD is an effective treatment modality for Barrett's neoplasia, with high en-bloc resection rate and low adverse event rate. However, with the exception of one randomized controlled trial comparing outcomes of ESD versus EMR, there are really no high-quality studies evaluating this important issue. So as such, the choice between EMR versus ESD for the treatment of Barrett's neoplasia depends on several factors, including operator's preference, lesion characteristics, and local expertise. In our institution, we routinely perform both EMR and ESD. Visible lesions less than 20 millimeters are routinely resected with EMR, whereas ESD is reserved for larger lesions, particularly those with a protruder or slightly depressed morphology, or lesions in which submucosal invasion is not well defined based on index histopathology. In these cases, en bloc resection provides an optimum specimen to guide subsequent therapy. We also utilize ESD as a rescue therapy for resection lesions where extensive submucosal fibrosis is encountered. It is important to highlight, though, that Barrett's esophagus is a field abnormality. As such, if ESD is not performed for the entire Barrett segment, the residual flat Barrett segment should be treated in order to avoid the development of synchronous dysplasia. So in summary, ESD appears to be safe and effective for the treatment of Barrett's neoplasia and is associated with low adverse events when performed in expert centers. While esophageal stricture formation remains the most common delayed adverse event, this can be successfully managed endoscopically. Ultimately, careful lesion characterization and selection plays a crucial role in determining the most suitable strategy for each individual patient. Thank you very much for watching this video, and I welcome all viewers to see our article in gastrointestinal endoscopy.